Thank you for tuning in to the Health and Social Care Business Podcast. Here, we highlight the people and businesses making a real difference in the sector, from everyday challenges to big industry shifts. We explore the issues providers face and how experts and organizations are stepping up with practical solutions. Our goal is simple: to bring you relatable insights, real stories, and actionable advice to help you navigate and thrive in the business of health and social care. Today, we're honored to have Geraldine McMurdie, the dementia specialist at Quality Compliance Systems. Most of you might know this as QCS. Geraldine brings over 15 years of leadership experience across the NHS, local authorities, and third sector. She's a registered mental health nurse by training. She's dedicated to her career in advancing dementia care, workforce development, and health equity. Currently at QCS, Geraldine leads an initiative to enhance dementia care practices, integrating digital innovations and evidence-based tools to support care providers. Her work is informed not only by professional expertise, which we'll get to hear more of later, but also by her own personal experience, having cared for her family members living with dementia. In this episode, we'll delve into Geraldine's journey, her current projects with QCS, and her vision for the future of dementia care. Let's dive in. Thank you, Jerry, for joining us.
You're very welcome. Very, very pleased to be here. Thank you for inviting me.
Okay, so could you please share your journey in health and social care and what led you to dementia care?
Okay, so we're going back about 40 years now. When I was obviously towards the end of sixth form at school, my mum had always worked in health and care for many years, and an area that I was naturally interested in. So initially looked at nursing and occupational therapy, but then sort of decided nursing may be more appealing. But I didn't actually want to do the traditional RGN, general nurse training. Something about psychiatric nursing piqued my interest. I thought, well, that sounds a little bit more unusual, a bit more interesting. It's kind of understanding how people's minds and behaviours sort of tick and play out. So essentially, I applied to do a registered nurse or registration course, and one thing led to another, qualified as an RMN, registered mental nurse, back in the late 80s, and then worked in a variety of mental health services. Some of them were for working age adults. Tended to see the more rarer types of maybe dementia in those sort of working age adult services. So some dementias where people were alcohol related. So Korsakoff syndrome is one that obviously springs to mind. But I also worked through my career in health and social care roles. So as well as working in mental health nursing, I moved into adult social care and worked in a range of roles for a local authority, but used my mental health nursing and dementia nursing experience, particularly in that world, because clearly, obviously, within adult social care, local authorities support both people, working age and older, but the roles that I tending to work in the older adult space, and more often than not, my expertise and knowledge as an RMN was called upon directly and indirectly. And then the Mental Capacity Act came out, and it was a particular area that interested me. So that led to a move from, I suppose, kind of field work or operational work into policy and strategy work with the local authority. And then that also led to other roles which moved across more into strategy and then commissioning. So I've worked in a range of roles in the NHS and in local government, adult social care, but have also moved into work in the independent sector for care home companies and the third sector. But I've always used my mental health, nursing and dementia knowledge and expertise in pretty much all of those roles. So it's always something I've been able to draw upon. And then sadly, probably about maybe 15 so years ago, my father started to show signs of vascular changes, initially mild cognitive impairment, but it then progressed to vascular dementia. So as a family, we've also been living through that and the ups and downs that entails, which obviously gives you a different and a deeper insight into dementia and people's experiences and the way it can impact the wider family and a family circle. And I think that hopefully gives me a very rounded understanding of dementia care and how little things make a big impact, but also how working in with across different agencies and organisations, and how kind of communication is such a key facet of good dementia care, both within an organisation but also across those organisational boundaries.
Thank you so much, Jerry, for that very clear description of your journey. One of the reasons why I'm really excited to have you on today is because, like you just described, you've worked at the local authority, commissioning, and you also have lived experience as well. So for people listening in, your contributions is not just going to be from a professional perspective, it's going to be from a personal perspective too. And I find that the most valuable contributions to conversations like this are from individuals like yourselves that not just bring it from theoretical, but also practicality, the emotional aspect. So yeah, I'm really excited to delve into that with you. So speaking about professional experience, your role in QCS is a dementia specialist role. How does this support care providers in delivering dementia care? You've mentioned that you've worked across various fields and you've worked for independents, but in particular, I want to know how the QCS itself supports that. And the reason I'm asking is because lots of people use the QCS app and they may not know that this exists. And even if they did know, I really want them to tap into this because we do have clients, like I said, that rely on this. So yeah, how does this actually help them provide a better care? Yeah.
Okay, thank you. So I have been at QCS just over a year as the dementia specialist. My predecessor who set a lot of this up in motion in QCS was Jackie Poole, who many people who particularly work in the dementia field will know of. She's a well-renowned occupational therapist, and she worked with QCS and developed the Poole assessment level, initially a book many years ago, I think originally back in the late 90s. And then eventually, if you like, stars aligned, and she worked with QCS to develop that into a digital assessment tool with additional resources and support based on the PAL assessment theory and practice, the model of support. And what we've also done in QCS is build and expand on that with the Dementia Centre that was developed around 3 years ago with Jackie and colleagues at QCS. But also what we've done in the last year or so is look at enhancing that, adding more practice-based guides, clinical information and support, and also helping, I suppose, the user interface so that if anyone uses the Dementia Centre, they're able to also navigate and find things easily and quickly. But so as well as having the TIS guidance, best practice sort of tools and resources, we're also very cognizant of making sure that when somebody needs information or guidance, they can find it easily and quickly, and they're not having to navigate a big site and get lost in it, in all of the resources that are there, because we have a lot of support and guides in there. We've broken it down into around 14 kind of domains within the Dementia Centre. So hopefully that enables customers to find what they want easily and quickly. So we've got, for example, resources focused on the PAL assessment, which is a internationally known assessment tool, but it's a cognitive assessment tool. So if somebody's living with cognitive impairment or dementia, the PAL assessment is based on providing the right level of support at that time. And it's based primarily on 4 support levels, which start with what's described as the planned level, which is probably the very early stages of dementia, giving guidance and support on how you can give the right level of support and support that's in tune with the person's abilities. So it's still very much based on trying to draw out the person's strengths and abilities in a very person-centered way, but also being able to show with effective and, if you like, applied skills and knowledge how you can support them from that early stage right through to the more advanced stages of dementia, which reflect the reflex stage within the PAL assessment. And within that assessment, which is digital, it's very user friendly. So we've been very cognizant of making sure that it's something that anybody with perhaps modest training and understanding would be able to use, as long as they know the person really well. It's based on those, responses based on the 4 support levels, and it covers 9 activities of living and communication and using objects. So it's a holistic assessment that looks at a whole range of activities and actions and the way a person can communicate. Then it gives you an overall assessment profile, and then it populates guides and useful information to help you support that person with activities like washing and dressing, using objects, taking part in activities, communicating. And in addition to that assessment, we've also got an engagement measure. So again, it's based on purposeful practice and meaningful support, but that's something a supervisor or trainer can use to observe a staff member and give feedback in a way that's supportive, but also focused on how they can improve and build their skills, and that helps them to understand, by using sort of reflection, but also the guides in the Dementia Centre, how they can better support somebody and also learn and acquire skills in what good looks like in terms of dementia care. So we have a range of resources, both based on the PAL assessment, the engagement measure, but we also have information on culturally competent care, on clinical information around dementia and other comorbidities, like how to support people with sight loss. Some of that information is from trusted external sources like Alzheimer Society, Dementia UK, or the NHS. And we also have our own resources that we've designed as bespoke support for our customers as well. So within QCS, we've got a range of products and solutions to support practice care providers. We've got our compliance centre, which has all our policies and guides, and a resource centre with best practice guides. And a lot of people know us for that. But we also have the Dementia Centre, which people can have as part of a package, or they can have as a standalone solution or product. You can buy that just as an offer, and you can also have our audit centre, which again provides a whole suite of support around governance, conducting audits. It has audit toolkits there and guidance, and also enables you to be able to track and monitor audits, outcomes from audits and actions. And we've also recently purchased a care management system. So within the whole QCS family, you've got pretty much everything. We want to make sure that when our customers come to us, they can get everything. So we're constantly adding and evolving based on what our customers need, what we feel will add value to them. So right through from your care management, you've got care management resources and a robust care management system. You've got our compliance and resources centre, you've got dementia centre, you've got an audit centre. You can have all of those or part of them if you so wish. So we're very mindful that we support providers, care providers who are starting out, who may just want maybe a smaller offer, right through to the whole suite of support. And we've also bringing in other tools and resources like an AI tool that we're launching this month to support our customers in care management, but also with using and accessing our compliance and our policies. And we're bringing in other resources around learning and development very shortly. You'll hear something soon around that. We've got HR support as well that customers can access. So we're very mindful of trying to avoid people having to go all over the place for different solutions and providing everything in one stop.
So when I started in the care industry, QCS was one of the solutions that I used. And one of the reasons I loved it, and this is not me advocating for QCS, is it actually guided my learning. And yes, I know with QCS initially, when I started using it anyway, it provides with templates, but the templates are very well structured. And what I loved about it is it actually outlines exactly where the information, how it was acquired, where it was acquired. So when you were making reference to the dementia, the other dementia specialists that co-produce the Dementia Centre, I just thought, yeah, that's typical QCS. What I especially love about the centre is it literally covers everything. Like you said, it's holistic, from assessments to care planning, care delivery, CQC support, HR. It's brilliant. And then you also mentioned the Dementia Centre could be used as a standalone or an addition. So does it mean that, for example, if I was an unpaid carer, I could actually use the dementia supports Does it mean that, or do I have to be a registered provider?
You would still need to be a registered provider at the moment, but it is something where, it's interesting that you mentioned that, because it's something we are looking at in terms of what we might move to and where we may evolve in order to offer a range of options for different people, whether that's the independent sector, third sector, potentially, families or the public, because we're aware that things are changing, the world moves on, the world evolves, and we're very conscious that we need to evolve and move with it. So it's always something we've got an eye on, and we are probably likely to consider, but we obviously need to get the model right, because we're conscious that there may be families living and supporting a family member with dementia in very difficult circumstances. We have to produce these resources as a business at the end of the day. So we need to get the balance right. So we're very conscious of doing something and doing it for the right reasons, and keeping that integrity and those values very close. One of the things that attracted me to QCS was around the strong value and that runs right through the company. And that's why we try and collaborate with, if you like-minded companies and organisations. We're very keen to make sure we promote the sector and support the sector. That's why we offer quite a wide range of free resources as well, so that people can obviously have a look at what we offer, but also that is giving, if you like, our knowledge and expertise and trying to share that with colleagues and partners around the sector, because at times we know that's the right thing to do, but equally it helps us understand and get and build, I suppose, that engagement with the wider sector, because there's lots of challenges, lots of very strong headwinds right now across social care, and it is very challenging for customers of all shapes and sizes. So we're very cognizant of that. We need to obviously be effective and successful as a business, but we also understand the world that our customers have lived and worked in. Many of us have worked in the sector. That's the other big thing around QCS. There's a number of us that have worked in the sector and still have a strong link to people working in the sector across health and social care. So we, have internal conversations about making sure we're doing the right things, and also having products and services that are easy to access. They're trying to make it easier for people to provide great care, supportive care, compassionate care that's person-centered, but in a way that doesn't disrupt their day-to-day work. And
that's so important, because it's so difficult managing a care provision and then having to navigate all of these various digital tools, or more or less even trying to understand one digital tool. So speaking about providers, I know you've worked with multiple providers and multiple agencies as well. Let's start with the most common challenges in dementia care.
I think the most common one is that most people living with dementia, by the time they're probably presenting to need support or help, are probably living with other conditions as well. So it's not just a dementia. It may even not be a diagnosed dementia, but they may have suspected dementia, because we know there's a challenge for people getting a timely diagnosis as well. But by the time they may get that diagnosis, they may have other needs that have also, if you like, come through. So for example, there's a high proportion, maybe around a third of people might have some sort of sensory impairment. So they might have hearing loss, visual impairment of some type, or both. They may also be living with chronic pain and conditions like diabetes, high blood pressure. All of these things have an impact on someone's general well-being and how their dementia can affect them. So if I refer to the guru of person-centered dementia care, that's Professor Tom Kitwood, who originally wrote back in the 1990s about person-centered dementia care. He talked about fundamental principles around what good person-centered dementia care consists of. And that's often, if you like, referenced or quoted, and it's certainly something that's built in, embedded into the PAL assessment and the PAL assessment resources. So for example, he talked about the importance of having comfort, that's protection, but also safety and warmth, attachment, and being included and feeling included, and having inclusive care, and supporting the person's identity. And that obviously talks to things around, their history, their personal history, their kind of experiences, and also occupation. And that's important because it's around having meaningful care and support that's relevant to that person again, and helps to engage them. It's not just an activity for the sake of activity, but looking at what's going to appeal and be, if you like, applicable for that person. So again, with our resources and our PAL assessment, that can help you identify, based on someone's history and preferences, and also their abilities, the sorts of activities that are likely to have meaning, and they'll derive enjoyment and a sense of purpose from that. They don't always have to complete the activity, but the whole process of taking part and, if you like, reigniting those connections can be meaningful and positive in itself. So, those 5 principles, which, if you like, are part of what's described as the Kitwood flower, with love at the centre, are, if you like, the cornerstones of person-centred dementia care. It's something that resonates highly with me and many practitioners, and it's something that, if you like, is part of the value set that you'd look up for anybody wanting to work in social care, to be perfectly honest, not just dementia care. But he also talked about how, because some dementia is a neurological condition, so it is a process, if you like, a disease process, a pathological process, and how it affects the person will vary on which parts of the brain are affected, but also a whole range of other factors. So he also talked about the, if you like, the dementia formula, which looks at a whole range of things that can affect the variance with people living with dementia. So the reason it can be a challenge is one person with dementia is often one person with dementia, and you can't copy and paste, if you like, the support you may give. You do need to understand what makes that person tick, understand their history, their background, what makes it difference to them, what is meaningful for them, and also, understanding the relationships they have with people around them, where they are, and which relationships have a lot of strength, a lot of, if you like, power behind them, and use that and draw on that. Because we all communicate in different ways, and it's important to understand that person, not just the person in front of you and how they present now, but also what's happened before, to help support them in a person-centered way. So that's why the importance of having a life history, profiles, using that information. So not just taking a life history and recording it and putting it somewhere in a folder and never looking at it again. It's making sure that that comes to life and is part of the care and support plan that you have in place to support them on a day-to-day basis. Because those little things around understanding their background, their history, can make all the difference in how you might connect with them, how you communicate with them, how you can understand why something, that might happen either at home or in the care home can suddenly make somebody feel either anxious or agitated or happy and positive, because it may have some resonance with their past life, their previous history, etc. So understanding that whole person is really, really integral in having a really person-centered approach.
I'm learning from my own personal knowledge as well. So you mentioned that the common challenges found is timely assessments, and then you linked this to the person-centered approach. Of course, person-centered approach is a huge part of the assessment, because like you mentioned, you have to understand the past history for you to actually give them the best care possible. So am I correct in saying that the Dementia Care Centre is based on the PAL model of supports, rather?
It is, and that is, if you like, the heart of the Dementia Centre. So the PAL assessment, the PAL model is very much an integral part of our Dementia Centre. But we have also built on that with other practice resources. But PAL is, if you like, the golden thread within our Dementia Centre, right from the PAL assessment to the PAL engagement measure. We've also got a staff competency and practice tool. So that's another element of the PAL approach, where you're looking at how a staff member can also look at how they develop their own skills. They can use that to reflect on how they may be able to grow and develop more applied dementia support skills as well. And we also have other guides like if you were working in a care home, we've got a physical environment assessment tool. So that helps a manager, a senior leader look at their whole environment in the care home, and it gives you a rating on things that will be, if you like, positive and will be supportive, but also advice on things that you can do to adapt and make some changes, and also activities that you can also put in place to help make your environment more dementia friendly. We
Is
also
that
have
a stage of dementia, or is that for every stage, or
that's the environment, the physical environment tool would be for any stage of dementia. It's looking at the environment, because the other key aspect of good dementia care is looking at the environment, what's going on in the environment, and that includes the person's own home. So as well as having guides for care homes, we've got tools and guides that will be really relevant for somebody living in their own, and perhaps having support from domiciliary care or in a supported living setting as well, because the environment is a key factor in how that person feels, interacts, and how they're able to, if you like, navigate and live well with dementia or not. So, you know, we do see that when somebody's environment suddenly changes, so for example, they may have to go into hospital suddenly for a planned or even an unplanned event, that will have huge disruption for somebody who has dementia or even mild cognitive impairment, because generally acute hospitals, they're busy, noisy places for obvious reasons. They're not really dementia friendly places. I know acute hospitals have tried to do an awful lot to try and, if you like, mitigate some of that, and some of that they have done with some success, but they are still very busy, noisy environments by their nature. So you need to understand that and maybe make additional, if you like, adjustments or accommodations to help keep that person feeling safe and comforted, reduce their distress, because, you know, you've taken them out of what's perhaps been their safe place, where they feel anchored, they feel kind of close to, they understand who they are, and you've taken them into a situation where they may lose their sense of self. And dementia is often linked to sort of a feeling of, if you like, personhood and identity, and losing maybe touch of that at times, because the changes in the person's memory, loss of memory, past memories, and their sense of themselves is often disrupted. So if you disrupt that again by suddenly taking them into a new, strange environment, you will some distress, or in some shape or form, or withdrawal, and you need to understand how you can support them in that setting. And again, we've got within the Dementia Centre purposeful practice guides that help staff members look at what they can do to support somebody in the right way, but also help them reflect how that person's behaviour may be their way of communicating something to you. They may not be able to tell you, but that's where understanding those non-verbal things that somebody can do is another way of them communicating either some distress, some pain, anxiety, and helps you to maybe adapt your approach and understand what may be going on, so that you can support them in a way that enables them to feel comforted, to sort of bring them back to their sense of their self as much as possible.
Very clear, very clear. Can we talk about unpaid carers and family? I know we mentioned, I asked earlier if the Dementia Centre can be used by just providers only, or other people who aren't providers, and you made it clear that it's something that it's in the works, but currently not. But in terms of advice for providers who are working with unpaid carers who may not have access to the Dementia Centre, what advice do you have for them, and how can they also work with them? Because sometimes, as you're aware in your previous role as a commissioner, or working in commissioning rather, you share time. You've been commissioned to give respites, as an example, or the care times, rather, for want of a better word, is being done by someone who isn't a provider, quote unquote. So how can they share resources using this centre?
It is for providers or organisations. That's the model we've set up. However, I will suggest, and I do this with friends who also, you know, might ask for advice around a family member. You know, we have got some really excellent organisations that provide guidance and information. So, you know, to particularly highlight Alzheimer Society, Dementia UK. But we also have some other organisations that are providing support and guidance on around more culturally competent care. So two that I could highlight there are a gentleman called Carl Case and Dr. Karen Jutler, and there's an organisation called Tide as well. And depending on what type of dementia the person might have, if you've got to a stage where you have a diagnosis for younger people, so people under the age of 65 is generally determined as young onset dementia. There are organisations that are now specifically providing guidance and support. I think there's the Young Onset Dementia Network. I think then that's the name of the organisation. If you Google that, you'd probably find them. And they've set up particularly to look at supporting people who may get dementia at a working age. So dementia isn't just something that affects older people. It can affect people in their 30s, when they're just about setting out, maybe on their careers and having families, or may have sort of teenagers. So it has obviously a huge impact, but a different impact, and things that need to be considered then maybe around what you do with family, children, work, your work and career. So there are, as I say, organisations depending on the type of dementia that you can get advice and support from, even if you haven't had a diagnosis and you suspect that a family member may be starting to show some signs of dementia. There are particularly good guidance and if you like, checklists the Alzheimer Society have created to help you have those conversations, if you like, those difficult conversations, and then take that forward to then maybe discuss with the GP to then look at things and take things further. It's important to understand that memory related problems aren't the only sign and symptom for some dementias. They can sometimes present quite late on in some dementias, like frontal temporal dementia. Memory problems aren't usually the first thing. It's normally things around language and maybe sometimes behaviour, the person doing things that are very, very uncharacteristic, but also having problems with their language and speech can be more of a sign for that type of dementia. But it's important to understand and get support and advice early on, because sometimes it's not always dementia that can cause memory problems. So people might be panicking and thinking, oh, mum must have dementia. It could be depression. That can often have similar presentations or appear in a way to some people as if they may have memory problems, when it's actually possibly depression or even a hormonal related imbalance with their thyroid. So it's important to get these things checked out, because often you have to exclude lots of other things before you make a diagnosis of dementia. And a GP, has a lot of guidance and knowledge of how they should be doing that. And then there are national, if you like, protocols that are also there to help people follow, if you like, a pathway around getting the right care and support, and then getting that diagnosis made in a way that's done looking at a range of tests. You wouldn't necessarily just do one assessment and then diagnose. You shouldn't be. You'd look at a whole range of things. And that includes, getting a history about what's happening over many months, ideally, not over a few weeks. So if you are thinking about that, it's important to be prepared, maybe with some information to give you and share with your GP about how that person's been over maybe several months, because they'll often ask, okay, when did you first notice things weren't quite right? What was it? And maybe start recording or writing some concerns down with dates, so that you've got if you like, a chronology, and that's really helpful for helping with diagnosis and understanding what could be going on, and whether it's dementia or something else. So those are the sorts of things I would say to people. I know it's a real worry, and it's probably, 30 years ago, cancer was the diagnosis everybody worried about. Now I think it's dementia. But there is support out there if you get it at the right time. And for some people, there are some medications, depending on the type of dementia, that can help as well. The earlier you get access to that, the better, really. So that's why it's better not to worry in silence and thinking, we'll just muddle through. It's not, if it is dementia, something you can keep muddling through, because sooner or later, either the dementia or another health issue will kind of impact things, and you'll need that help. But it's better not to wait for the crisis, and to try and plan and prepare and give yourself information. Everyone's different. The
Mhm.
reality is not everybody wants a diagnosis. Some people are still very fearful. There's still some stigma.
Yeah.
And we're trying with, raising awareness, sharing information about dementia, trying to reduce that fear and that stigma so people don't think it's the end of the world. Because if you get the right support and make some adjustments, so sometimes, some life changes in terms of healthier living will also have an impact. We're finding out more and more about how living well makes a big difference. The things that we all know we should be doing have a big difference, whether it's managing your diabetes, your blood pressure, being active, doing strength-based exercises, things that we all should be doing anyway once we hit our 40s, to be honest, will help keep us all mentally and physically well. And the biggest one I'd also stress is about the importance of sleep as well.
I could hear from your narrative rather that you do promote early intervention, because most of what you've said it relates to early intervention, assessment based. Get the assessments in. Don't be scared. You're trying to make people comfortable enough to approach the right individuals or professionals when they feel there's a problem. So the key message for dementia, from what I've heard from the last couple of things you've said, is early intervention and keeping records so that the GP can use that to properly assess. How about when it's progressed? Interesting. How about support for families?
Indeed. So yes, obviously I've talked about kind of with my mental health nurse hat on the kind of preventative or early support and intervention side, but equally living well with dementia is just as important, because for most people they'll be living with dementia for 5-10 years plus, depending on what stage and what time the diagnosis is made. And it is a progressive condition. It will advance over time, but actually how you, if you like, live and support that person has a real bearing. So as well as looking after and trying to adapt things to help them, so for example, in someone's home environment, it's important not to do too much to change the home, because it needs to remain familiar to them, because their home is kind of, if you like, their anchoring space. So all their past memories will be tied up within that home, often if they've lived there for many years. And the location of items, rooms, that layout will all be very familiar to them and be embedded in their memory. So we've got different types of memory that help us with all sorts of things without us consciously thinking about it, from, if you like, procedural memory, so things that we do without thinking, we've learnt many times because we've done them thousands of times throughout our life, whether that's eating and just picking up a cup, that includes procedural memory. But also the layout of things, where things are in our house, in a particular room, where they've put things in their kitchen, that will all be familiar to them. So if you start making lots of changes, that's going to completely disrupt somebody's sense of place and orientation. So be mindful of doing things with the person and trying to do it with their blessing, so that they don't feel they're being done to. I think is really important. There's likely to be a feeling of losing control anyway, and that creating a lot of fear and anxiety. So the worst thing to do is come charging and saying, right, mum, we're gonna have to do this and take this away and do, because that's very disabling for the person. And you're also maybe treating them a bit like a child, and that's something that you shouldn't be doing. They are still an adult. Yes, some of their abilities may be changing, but we also need to adapt our approach to them and adapt, if you like, to their new world as much as possible. But practical things that you can do, particularly in someone's own home, is looking at things like the lighting. Generally, as we age, we need more light, so making sure that you've got good powerful bulbs, the wattage, or if you like, I think the lux, as they describe it in the lighting, needs to be probably at a higher level, because we need more light to see things clearly as our eyes age, regardless of whether we had dementia or not. But that can also help reduce the risk of falls by having good lighting, reducing sort of shadows or stairways that are darkly lit, because again, it just makes it easier for people to navigate. You can find with some dementias, particularly with vascular dementia, you might have difficulties with walking, in particular, and balance. So if possible, maybe try and see if you can use ramps or put in additional things like, you know, stair rails or rails in the bathroom, again with their, you know, permission and talking it through, so you're not coming in and taking over and completely sort of dementia proofing someone's house, because that might go down very badly for the reasons that we've talked about. But it's also important to get help for yourself and support for yourself. So you'll usually find that there are support groups, whether it's, you know, Alzheimer's Society, Age UK, or other local organisations, charities that will have, you know, support groups. Some of them are for the person living with dementia and family or carers to go along together. But it's important that you know, you don't try and be this super rock, that if you're struggling, and you might not always admit that you are, just talking to someone else who's living that experience can help and be enormously helpful, and just release tension yourself. Because if you're anxious and tense, you're not going to be in a good place to provide the best support and care.
No.
You don't necessarily always realise it, but that's why it's important to take advice or to take support if it's offered to you. And also, you know, get in touch with local groups, because you might not need it today, but maybe in a few weeks or months' time you might need it or appreciate it. And sometimes it's just little things that somebody might mention to you that can make a huge difference to how you're managing and how you're feeling. And also trying to keep socially active for both the person living with dementia and family and the carer is important. It's very easy for the person.
What does it look like, socially active?
Well, it's very easy for your world to get smaller and smaller if you're living, you know, particularly in the community, in your own home with, you know, maybe a spouse, and they tend to sort of think, oh, we can't go here anymore, because, you know, they're kind of thinking that they've got to prevent certain events or crises happening, so they think, well, it's easier not to go out there anymore, so it's easier maybe not to go to church anymore, it was easier not to go to this, you know, social club or whatever. But actually, you know, more and more organisations and places are trying to become more dementia friendly, so it might be easier to have a chat with the organisers and say, look, we think this is happening with mum, we'd like to still keep coming, but we're finding, you know, this a little bit difficult, can we come maybe at a later time, or can we, you know, leave or go earlier? Maybe they could make adaptations to help make that easier for you. Right. But if they don't know, they'll maybe just assume that you don't want to come anymore and, you know, lose contact with you. And sometimes there are organisations that will do, you know, home visits and come and do sort of small, you know, social one-to-one type visits to reduce someone's isolation and just, you know, help keep that person socially connected, because social connections really important for people living with dementia if they're a social person. And again, don't make assumptions. If somebody's not been a social person in their life and soul, they're not suddenly going to become that just because they've got dementia. So again, it needs to be, you know, based on the person's preferences and their kind of personality and all of those things, really, so that it's in tune with what would work for them. But it's also, as I say, when somebody's living with dementia and it's progressing, you know, if things are changing, do reach out to your GP, because they may be able to refer you to other services and other support that may be appropriate at that time. So it may be that you may need help with things like podiatry, because, you know, there are issues around walking or not walking easily, and maybe some advice from that sort of specialist would help. And if somebody's in a care home, equally the same. I know, you know, care home staff will have some degree of training, some are better than others, which is why we advocate our dementia centre to give that support and continual sort of access to guidance and best practice. But it's also important to ensure that you've got the right environment within the care home, get access to outdoor space, because that's really, really important, particularly just for general, you know, we all feel better when we're outdoors and we're closer to nature. So even, you know, just having, even if it's a small garden, but having some, you know, trees, plants, if they're edible, with raised borders, lots of scent and, you know, smell, you know, really therapeutic. It can bring back, you know, powerful positive memories, and people can take part in gardening type activities, even if they're just holding a little trowel for sort of a few minutes and digging around and playing in, you know, with the dirt, doesn't necessarily mean they have to plant anything, but again, it triggers positive memories. It's something that they can use and connect with others and talk about. It can, bring and, if you like, elicit conversation about what people used to plant and what they used to grow in their gardens.
I believe things like that, and this is having worked with providers, they may be fearful of that having an adverse reaction, like a negative reaction, because they might not be familiar with that space. So as opposed to what you're saying sounds great, changing the scenario, being social. However, what then happens when the reaction isn't as you're describing?
And sometimes, that can happen for a whole range of reasons. So somebody may become very agitated or distressed or sort of, and it may be because of a whole, unmet need. So it could be pain, and pain's often underdiagnosed and undertreated. So you need to somebody having pain, chronic pain, could be arthritis. You're asking them to get up in the morning in particular. Well, when you get to a certain age, things get a lot stiffer to move in the morning, and you can have quite a lot of pain. If somebody's sort of coming in expecting you to sort of get out of bed, without being mindful that your joints are maybe quite painful, you might not have even had a good night's sleep because of some pain. It's important to understand and there's a particular, if you like, advice that we give around looking at pain management, and there's a company called Pain Check that have some software that has facial recognition, and it's been developed and tested in care homes. We work with them as well, because it's called Pain Check, and it's been developed with that in mind to help people who may be non-verbal, but may be in pain, may be unable to verbalize their pain, but actually it can manifest its in what people might describe as distress behaviors, but actually the person's got a lot of pain and you're trying to get them to move and get up when actually they're in agony. And the natural thing is to push somebody away. If somebody's sort of pulling at your shoulder and your shoulder's really stiff and painful, you're going to push them away. That's not a distress behavior. That's probably a very natural behavior, but you haven't diagnosed or assessed and understood that they're in pain. And if they may have dementia, they may not be able to tell you, or tell you in a way that you may not understand. So that's one of the big things we suggest, is you look at whether the person's in pain and having good pain management throughout the day, and being mindful of that being a potential trigger. It may be that something's happened prior to that initial interaction that's maybe caused some upset. So sometimes, we don't always support people in the right way. We can make them feel anxious or distressed, and they will maybe be left with that feeling for a little while. They may not be able to tell you that something's happened to make them feel upset. And then you're the next person that comes along, and you perhaps get the brunt of that reaction without thinking, well, what did I do? I've only just come to them. It may be that something's happened earlier on, maybe half an hour or so before. They can't remember what's happened, but they've been left with that emotion and that feeling. So it is important to have a consistent approach when you're supporting somebody, and have your care team understand why that consistent approach is important. And sometimes it may just be that, that person's just not in a good place, and you need to just leave them for maybe 5 or 10 minutes. And sometimes just go back 5 or 10 minutes later. And sometimes it's just around kind of not being the right time, and things just not feeling right for them, where they just need to be away from people. And you've come in, particularly if they've got something like a sensory impairment, and you haven't maybe approached them in a sensitive way and just walked up to them, maybe startled them, and then again their natural reaction will be, what's going on? It's all those little things, you need to be considering when you're communicating with somebody, but also look at the non-verbal things that's going on. When you get to know somebody, you get to know those little signs that whether they're in a good mood or not, whether they're in pain or not. So that's why observing and getting to know people has a real benefit, and having consistency is really important, and keeping to routines as much as possible is also important. It gives the person a sense of continuity, and a sense of sort of routine, and anchoring. If things are happening at a fairly regular time, it helps them, I suppose, navigate and get through the day, really, by having that consistency.
Yeah, dementia care is really a specialist care, because we know it's a specialist care, but you kind of say it sometimes repetitively, because
Mm.
whenever you say dementia, you have to say the words it's a specialist care. But just from listening to you, you're reinforcing and reminding us all that this really is a specialist area and you have to approach it as so. So, dementia is a cognitive related disease and it's progressive.
Yep.
So, we have to talk about mental capacity. I know you've mentioned
Mm. Mm.
assessment and the importance of it, and early diagnosis, early detection, early assessments. One thing that I'd really like you to discuss, and this is an area where providers struggle, especially when you read CQC reports and things like that. And also, you spoke about including the individuals at different stages. So, of course, mental capacity is
Mm. It's a huge part of dementia
part of
care.
it. At
Yeah.
what point do you say, okay, I'm acting in this person's
Their
best?
best interest. Yeah. So yeah, thank you. And that's an important area because we do cover that in our dementia centre as well. We've got some specific worked examples on how
Okay, that's
to
good.
understand how to use the Mental Capacity Act, understanding not just ethos and the theory, but also some
I'm not
practical
that.
ways to
Yeah.
use it and share and record that you're complying with the act, both in the spirit and the word. So you're right. Obviously, when somebody has cognitive impairment or dementia, you need to be very mindful of how the Mental Capacity Act or relevant legislation in Scotland that's not the same, but it has a kind of similar approach and ethos, but equally, the principles around the Mental Capacity Act. And although, it's been around for about 17, 18 years, you're right. The understanding of it in day-to-day care and support and healthcare is still very patchy. Only, I think today I was reading about a case where sadly a gentleman, I think he had cerebral palsy and other health needs, had been living quite well in, I think, a supported living placement, and went into hospital, and the hospital, the care team, his support team, had sent in his passport and lots of information, what he needed, and the sort of, and it was, none of it was looked at and considered when they looked at best interests and planning his care, and so it just shows you now,
Exactly.
even
Yeah.
now, it's still not being applied properly.
Yeah.
So, we have got those
I
principles
love that
for a
clarity,
reason.
how to apply the Mental Capacity Act, because a lot of times when you're reading regulations, even the word itself is not written in everyday language. So translating that and using a unified language that in layman's terms is so important when you're interpreting
It
regulations
it
or
it, it absolutely is. But at its heart, we have got principles that you need
yes,
to be very mindful of. So it is about, you know,
of course.
dementia, as you mentioned, it's a fluctuating situation, and people's ability to understand and have capacity can vary depending on the time and the situation, and that's very true. So nobody, nor automatically has, just somebody's been diagnosed, they're completely lost capacity. That's not true. Capacity is relevant to the context and the situation and your understanding of that. So it's being able to understand what's going on, to be able to weigh up the pros and cons of doing something or agreeing to something, understanding the risks and things of doing a particular action or not doing a particular action, and being able to decide whether that's going to be something that you'd want to do. Ideally, trying to foresee what the likely consequence of that is. So, for example, somebody with mild dementia might be in hospital, maybe had a urine tract infection, got very sick. Family are very, very concerned, saying, "Oh, should mum go home? We're not sure. We're not sure." Once they're recovered and had their antibiotics and fluids and everything, they're starting to say, well, actually, I want to go home. Now, just because they've had a diagnosis of dementia doesn't mean that they've lost capacity to choose and make a decision about that. They
Okay.
might need more time and support to understand, what going home means. But they may still understand that, yes, I know I want to go home. I've not been well. I've got some problems with memory, but I don't want to be in hospital. I don't want to go anywhere else. I can
Mhm.
manage, maybe I'm willing to help, get some extra help in now and take the risk, but I want to go to my own home. And that means that you've been able to support that person. They've been able to understand what the decision is being discussed. They've been able to take in that information, weigh it up, understand the implications, and communicate that to you. You know, that's what the Mental Capacity Act is about. It's about enabling people as much as possible to have supported decision making, to understand the risks of decisions, the pros and cons of decisions, and to be able to express their choices and wishes. Now, if what they say and express sounds like they actually haven't really understood all the implications, or they haven't understood what the decision is, then you might have a reason to think they probably don't have the mental capacity to make the decision. But the first thing is you shouldn't be assuming just because somebody has a diagnosis or they're a particular age that they lack mental capacity, because it is about looking at that approach from, okay, this person might have some dementia, it might be moderate dementia, but actually they can choose whether they want to have fish and chips versus a curry tonight. They can choose whether they want to, you know, go out in the garden this afternoon or not. And if they say no, well, maybe that's fine because they don't fancy going into the garden. You shouldn't have to interrogate them as to why they've said no. Sometimes no just means no. So it is also about understanding, you know, how you've supported that decision-making process with the person, if they're able to. And you look at how you can do that. So that's making sure when you're giving them information, you're giving it in a way that's meaningful for them, that they can understand. You've either broken it down, you can use things like pictures or diagrams. You know, there's lots of guidance in Code of Practice that show you how you can help with giving that information and sharing that information so the person's able to understand what's being said to them, what they're being asked, and what the decision is about. And then you also look at other factors. So, you know, you look at the time of day that you might be discussing something, particularly something important. So if they're likely to be a bit more confused first thing in the morning, well, don't have the meeting in the morning. Maybe have it later on at 11 when they've been up for an hour or two, but they're still fairly alert. And they're likely to be able to give the best, if you like, account of themselves. Equally, don't sort of have it sort of late on in the afternoon where they may be likely to get a little bit tired and confused, and therefore they're not able to contribute to the discussion or be in a meeting. And if you are having best interest meeting, then, you know, there is a way of making sure that that person's views, you can have maybe a separate meeting or conversation with them and record that and say, well, I spoke to Mary yesterday about this at this time where she seemed to be, you know, fairly lucid, and we talked about this and I asked her these questions, and record what they said, exactly what they said. So, you know, it's their words, so it's important to make sure that that's recorded. So it's a combination of meeting those principles, but also recording what you've done and how you've done it and how you've evidenced you've supported that person as much as you can to make the decision by giving them the right information in a way that's meaningful and accessible for them, what they've said, and on that basis, use that to help see if they've understood the risks, the benefits, what the decision is, and they were able to communicate that. Because if you look at the best interest principles, you know, it is really about best practice, and it was going on before we had the Mental Capacity Act. When people were doing things well, they were involving people as much as possible in the decision. If they couldn't be involved themselves, then people that knew them well were able to take part or give their views, talk about what that person would have wanted, so past wishes, that person's preferences, and also looking at things that are the most appropriate and least restrictive. So, you know, we're trying to support that person as much as possible without being overly restrictive in that approach, really. So it might seem a big nebulous piece of legislation and people might think, oh, it's too complicated, I can't get my head around it. But actually, we've got some, you know, really good guidance and practice guides in our dementia centre. But there are also resources, you know, online that people can access. I often say it's often what you would like to happen to you if you're in that situation. Think about it in that way, really.
So it's best to say, in summary, what underpins the best practice under the Mental Capacity Act is involving people, don't assume, and meaningful conversations for the individual you're engaging with. This is my own deduction. This is not my interpretation of it.
We have got the principles, so that those 5 principles are around, not assuming, and that, they're in the MCA legislation and the code of practice. So people need to kind of go and refresh their memories around those. But it is around, those 5 principles, and making sure that, particularly with somebody living dementia, you're making reasonable adjustments or adaptations to help them be involved in that decision and communicate that as well.
Adaptations, I like that. So on a final note, Jerry, we have to get you back, because I feel this is a subject that requires more. It requires updates because it's so broad. It's touched upon so many things that I wish we could delve into more. So this is me officially asking you for another podcast session much later on.
I'll be happy to come back. I'll be more than happy to come back. As you say, it's a very broad, multi-layered area.
That's the best way to describe it. Very multi-layered, because you mentioned something that got me thinking. Dementia can affect all ages, because I've always associated with getting older.
It's more common with age, and the biggest risk factor still is advanced age. However, sadly, we do have some dementias that just affect people in sort of what's called young onset dementia. So they could be in their, as I said, sadly, 30s, 40s, 50s. The more uncommon or rarer types of dementia, so Huntington's disease, Creutzfeldt-Jakob disease, but also, some vascular dementias sometimes present people in their 50s because of all the risk factors linked to vascular dementia, high blood pressure, high cholesterol, having strokes. Those can cause some people to have vascular dementia even before the age of sort of 65. And also frontal temporal dementia, that's probably one of around 10% of dementias. And again, that might start presenting in the 50s. Sometimes it gets diagnosed quite late because it's quite a subtle dementia to start with, and it doesn't have the typical, I mentioned, it doesn't have the typical early stage of memory related problems. It's often some behaviours and very strange or atypical behaviours, because it affects the frontal temporal lobes, where that's a part of our brain that kind of govern acceptable and antisocial behaviours, if you like. So when you've had a few drinks, for example, that's where your frontal temporal lobe sort of parts of it switch off a bit, and you can be a bit more disinhibited, say things and behave in ways that you maybe wouldn't normally.
Sometimes explains the effects of alcohol.
Yes, because it's some of that does mimic what happens to our brains when somebody has a dementia that's affecting the frontal and temporal lobes, because it might mean that they behave and say things in ways they wouldn't normally. So that's when in frontal temporal dementia you can find that somebody's behaviours become quite a worry, and they can often have very risk-taking behaviours, again because that part of the brain that manages risk and protects people from risk may not be working as well, or may stop working. So they may go and do things that are very risk behaviours or risky behaviours. So that's one of the kind of reasons that diagnosis might be made in somebody in their 50s. It could be that there's something going on, and it's that type of dementia. And also the other biggest risk factor is alcohol related dementia, and again that can present people in their 50s and sadly even 40s if they've been a very, very heavy drinker. It's usually linked to vitamin B deficiency, but if that continues, it can then become permanent brain damage, brain changes, which are sadly irreversible, and then you then go down that progression of alcohol-related dementia, sadly. So,
thank you for that clarity. So, on a final note, for providers and carers listening who are probably feeling overwhelmed with care, because from what you've just articulated, it's almost inevitable that if you're new, or if perhaps the person you're supporting is going through changes, there might be feelings of overwhelmness. So for carers and providers who are currently in that space, just one advice to them to end this lovely conversation.
Thank you. So I would say there are resources and guidance and support out there. Obviously we offer a particular support in our dementia centre for care providers, particularly adult social care providers, also healthcare providers if they so wish. And that does take you through a whole range of support and guidance and best practice information, as well as training related support. So it may feel overwhelming, but please reach out to QCS. We are there and very keen to offer that guidance and support. And we'll shortly be adding to that in our offer with regards to other training related resources. So please, reach out to us, talk to us. For families, friends, I've mentioned, those sort of trusted sources like the Alzheimer Society, Dementia UK, and we can, we often would signpost people to them. I've often signposted friends and family to them. It is a complex and sometimes complicated condition. However, at the heart of good dementia care is empathy, and just being prepared to give that person time to communicate, to process what you're saying, being present with them. Because one of the things the person will remember is how they felt when they're around you. They may not remember your name or always recognize your face, but they will often have that strong emotional memory of what happened to them and who they were with at that time. And they can often hold on to that right to the very end.
Wow, that's the perfect way to end this conversation. Thank you, Jerry.
Thank you. Thank you.
Enjoyed this episode. We would love to hear from you. Let us know what about this episode you liked and how we can improve. Join our growing community of providers and carers who are learning new processes and technology, discovering proven best practices, growing through insights from industry experts, all from people creating real practical solutions in care. This is the Health and Social Care Business Podcast.